Welcome to the deep dive. Today, we're tackling a really pivotal, yet often unseen, part of surgery that has a massive knock-on effect for patients, how things are managed during vascular operations.
That's right.
It's fascinating because these aren't your average surgical cases. We're often dealing with older individuals, lots of health issues.
Right. Limited physiological reserve and some truly complex procedures. What happens in that OR is incredibly important.
It really is. It's not just about getting through the surgery. It sets the stage for the entire recovery, doesn't it?
Absolutely. It dictates the whole postoperative course and ultimately how well the patient does long term.
Exactly. So our goal today is to really drill down into the most vital considerations for the surgical team, right in the middle of a vascular surgery. We've been through a really insightful chapter on this, and we're ready to pull out some surprising insights.
Yeah, some key takeaways.
Okay, let's jump right in with something fundamental. Anesthesia. How do you approach that in these often vulnerable patients?
Well, in vascular surgery, a one-size-fits-all approach just won't cut it. Tailoring the anesthetic is absolutely essential for safety and comfort.
Because they just couldn't tolerate the procedure otherwise.
Exactly. We need something, whether it's local numbing or full general anesthesia, to manage the stress and pain.
And when we talk about local or regional anesthesia, we're basically blocking nerve signals. How does that work chemically?
Precisely. Local anesthetics interfere with nerve conduction. They block neuronal sodium channels, the gates that let signals pass. Most of them have a similar structure, an aromatic ring, basic pH, lipid-soluble,
But they're given in an acid solution.
right, for administration. Once in the tissue, the local pH helps them bind and block those channels. There's a whole list of agents available.
Looking at the info, lidocaine and bupivacaine seem really common. Why those two specifically in vascular?
They are definite workhorses. Lidocaine's great because it works fast, rapid onset. Bupivacaine, on the other hand, lasts much longer, which is good for longer procedures or post-op pain.
Makes sense. And how does the body get rid of them afterwards?
Depends on the type. The ester-based ones are broken down pretty quickly in the blood by plasma cholinesterase,
Okay.
but the eminins, like lidocaine and bupivacaine, they need the liver to metabolize them. That's important if someone has liver issues.
Got it. And I heard too much can be dangerous. What are the toxic effects?
Yeah, unfortunately, dose matters. Too high, and you get problems. It usually starts with things like dizziness, ringing in the ears,
Tinnitus.
right, tinnitus.
Mm-hmm.
Then maybe anxiety, fear, tremors, even seizures, and in severe cases, coma.
Wow.
And here's a catch. If the patient also got benzodiazepines for sedation, those might actually mask the early warning signs, the neurological ones.
Oh, that's tricky.
And at even higher doses, you can see direct effects on the heart arrhythmias, myocardial depression. The heart muscle weakens.
Okay, so moving along that spectrum, moderate sedation or conscious sedation, what's that?
Moderate sedation is a really useful middle ground. It's drug-induced relaxation. The patient's consciousness is depressed, but critically, they can still protect their own airway.
So they can still breathe on their own, keep their heart rate stable.
Exactly. They should maintain spontaneous ventilation and normal cardiovascular function. And interestingly, it doesn't always have to be an anesthesiologist administering it.
Really? Who else can do it?
Other trained and credentialed healthcare professionals can, following specific guidelines, of course. The ASA actually outlines a whole continuum, minimal sedation, moderate, deep sedation, then general anesthesia.
And the main differences are responsiveness, airway support.
Right. Responsiveness, airway needs, spontaneous breathing, and cardiovascular stability. Those are the key distinctions across the levels.
So if someone's having moderate sedation, what prep is needed?
Careful preparation is key. Usually fasting, thorough history check allergies, past reactions, current meds, any conditions like sleep apnea or heart issues that could increase risk. And crucially, you must have rescue gear and meds right there, immediately available in case things go sideways.
And during and after, what monitoring is essential?
Continuous vigilance. That means constant ECG, continuous pulse oximetry for oxygen levels, and frequent checks of blood pressure, breathing rate, and their level of consciousness, both during and immediately after.
What kinds of drugs are typically used for moderate sedation?
Oh, several common ones. Midazolam, diazepam, those are benzodiazepines, good for anxiety and sedation.
Okay.
Then opioids like meperidine or fentanyl for sedation and pain relief. Propofol is another big one, very short-acting. and sometimes droperidol. They all have different onset times, durations, and side effects, of course.
And if there's a bad reaction, can you reverse these?
Yes, absolutely critical to have reversal agents on hand. Naloxone reverses opioids like fentanyl,
Right.
and flumazenil reverses benzodiazepines like midazolam. But here's the important thing. The reversal agent might wear off before the sedative does.
Ah, so the sedation could come back?
Exactly.
Yeah.
So even after giving reversal and seeing improvement, you have to keep monitoring closely. They might need another dose.
That's a really vital point. Okay, moving to regional anesthesia, you mentioned different types.
Right. Regional blocks nerve signals to a whole area. You've got peripheral nerve blocks, often for arms and legs, and they can give pain relief long after surgery.
Nice.
Cervical and brachial plexus blocks for neck-shoulder area, good for upper limb stuff. And then spinal and epidural anesthesia. Those are neuraxial techniques near the spinal cord.
Let's dig into spinal anesthesia. How's that different?
Spinal is usually a single shot right into the cerebrospinal fluid in the lower back. A key thing with spinal is the sympathetic blockade it causes.
Meaning it affects blood pressure control.
Yes, it can dilate arteries and veins, leading to potentially significant drops in blood pressure. So we generally avoid it if we expect the patient's hemodynamics might be unstable during the surgery.
And if blood pressure does drop.
Treat it with IV fluids, maybe the Trendelenburg position, feet up, and if needed, drugs like inotropes or vasopressors to support the heart and raise pressure, especially if there's underlying heart failure.
What about complications with spinal?
Well, the most common is probably that post-dural puncture headache.
The one that's worse when you sit up.
Exactly.
Mm.
Caused by CSF leakage. Feels better lying flat. Sometimes you get other things like double vision or ringing ears with it. Treatment is usually rest, fluids, caffeine, analgesics. Severe cases might need an epidural blood patch.
A blood patch.
Yeah, injecting a bit of the patient's own blood into the epidural space to seal the leak. Other potential issues are nausea, vomiting, breathing problems if the block goes too high or in COPD patients, and rarely nerve injury, Cauda-Equina syndrome, arachnoiditis, spinal hematoma, meningitis, or very rarely sudden cardiovascular collapse.
Scary stuff, though rare. Now, epidural sounds similar but uses a catheter.
Exactly. A thin catheter goes into the epidural space just outside the spinal canal, thoracic or lumbar level. We need larger anesthetic volumes than spinal because it has to diffuse across membranes.
But the big advantage is
Continuous post-operative pain relief. You can run a local anesthetic infusion through the catheter for days, often 3 or 4.
that must really cut down on opioids.
It does, significantly.
Yeah.
Reduces systemic opioid side effects like drowsiness and constipation.
Yeah.
And importantly, it usually doesn't stop patients from getting up and moving around, which is key for recovery.
That's a huge plus. Now, many vascular patients are on blood thinners. How does that affect using spinal or epidural?
That's a critical point. There are specific guidelines. You need careful timing waiting periods before placing the needle or catheter and waiting periods after removing it before restarting anticoagulant.
Depends on the drug.
Yes, the specific drug, the dose. It all varies. Low-dose heparin is different from therapeutic warfarin or a DOAC. It's all about balancing the risk of a spinal hematoma bleeding around the cord with the risk of clotting if they're off their anticoagulant for too long.
A tricky balance. Okay, let's shift to general anesthesia. What's the definition there?
General anesthesia means complete loss of consciousness. The patient is unarousable, even to pain.
Right.
They lose airway reflexes, so they almost always need airway protection, like a breathing tube and mechanical ventilation. And cardiovascular function can often be depressed.
How does it affect the body overall during surgery?
Many GA drugs cause peripheral vasodilation, blood vessels widen. They also inhibit the sympathetic nervous system's control over circulation.
So blood pressure can drop.
Yes, that disruption of autoregulation, plus no surgical stimulation right at the start, often leads to hypotension between induction and incision. That vasodilation also shunts blood to the skin, leading to heat loss and a drop in core body temperature.
Makes sense. And something we hear about is malignant hyperthermia. What is that exactly?
MH is a rare but potentially fatal genetic condition triggered by certain anesthetic agents, usually succinylcholine or the inhaled halogenated gases.
And what happens?
You get this hypermetabolic state, severe muscle rigidity, incredibly fast heart rate, soaring body temperature, cardiac arrhythmias. It's an emergency.
What makes it life-threatening?
The runaway metabolism, the extreme hyperthermia, and dangerously high potassium levels, hyperkalemia.
If it's suspected, what's the immediate plan?
Stop surgery immediately. The main treatment is intravenous dantrolene, a muscle relaxant. Give an initial dose, repeat as needed based on CO2 levels, heart rate, rigidity. Sometimes you need large doses.
Okay, dantrolene first. What else?
Hyperventilate with 100% oxygen, high flows.
Okay.
Put activated charcoal filters in the ventilator circuit to soak up residual gas. Change them often. Start active cooling if temp is over 38 degrees C. Ice packs, cooling blankets.
Address the metabolic chaos.
Right. Correct metabolic acidosis with bicarbonate. Treat the hyperkalemia with calcium, bicarb, glucose, and insulin. Importantly, avoid calcium channel blockers for arrhythmias. Refractory hyperkalemia might need albuterol, kayexalate, or even dialysis.
Sounds like a very intense, coordinated response. Okay, let's pivot again. Many vascular patients have chronic kidney failure. How does that complicate things intraoperatively?
You're right, CRF is increasingly common, linked to hypertension, diabetes, aging. And, unfortunately, it carries a much higher mortality risk, largely due to associated heart disease.
So the kidney disease itself adds challenges.
Definitely. Problems with fluid and electrolyte balance, anemia, metabolic issues, plus their underlying comorbidities. It significantly increases their surgical risk. Patients with end-stage renal disease undergoing elective vascular surgery, especially over 65, face much higher rates of complications and death. Perioperative mortality can be 3 to 4 times higher than in those without CRF.
That really underscores their vulnerability. What specific things need careful watching during surgery?
Several key things. Dialysis timing is important, preferably the day before surgery, to optimize electrolytes, volume, and waste products.
And fluids during surgery?
Very careful management. They can be volume overloaded or depleted post-dialysis. The type of IV fluid matters too. Balanced salt solutions might help acidosis but contain potassium. Normal saline avoids potassium but can cause hyperchloremia.
What about their anemia?
They often tolerate baseline anemia, but even small blood losses hit them harder, compromising oxygen delivery. If they need transfusion, it has to be cautious because of the risks of volume overload and hyperkalemia from the stored blood.
These are all critical points. Okay, let's talk about monitoring during the operation itself. What are the essentials?
Continuous monitoring is absolutely vital. It's how we track the patient's response to surgery and anesthesia in real time.
Allows for quick adjustments.
Exactly. Lets us spot deviations and adapt management to keep them stable.
So what are the standard monitors we'd see?
Well, ECG is standard across the board. Usually a 5-lead system for vascular cases, monitoring leads 2 and V5 typically. Though some evidence points to V3 or V4 being potentially more sensitive for ischemia in this setting.
And pulse oximetry.
Yep, the little finger probe measuring oxygen saturation. Yeah. Standard of care, even if the hard evidence linking it directly to improved outcomes in GA is a bit scant. Still essential for oxygenation assessment.
Right.
Then capnography measuring end-tidal CO2, that's the standard for assessing ventilation during general anesthesia, usually shown as a waveform.
What about blood pressure?
Often invasively measured with an arterial line, a small catheter in an artery, usually the radial artery in the wrist.
Gives continuous readings.
Continuous, accurate BP, plus it allows for repeated arterial blood sampling for labs.
Are there risks with the arterial line?
Yes. Potential complications like artery narrowing, thrombosis occlusion, which could compromise hand circulation. That's why it's crucial to check the collateral blood flow from the ulnar artery before placing a radial line, the Allen's test or similar.
Good point. Now, beyond these basics, what about more advanced hemodynamic monitoring? Central lines.
Right, central venous catheterization. A larger catheter in a central vein lets us measure CVK, central venous pressure. Theoretically, it estimates intravascular volume and venous return.
But it has limitations.
Big time.
Yeah.
It's affected by lots of things. Only correlates well with left ventricular filling pressure in patients with normal hearts and lungs. Positive pressure ventilation, patient positioning. They all muddy the waters. Absolute values mean less, but changes in CVP in response to fluids might be informative.
What about a pulmonary artery catheter? Sounds more involved.
It is a specialized catheter floated through the right heart into the pulmonary artery. Measures pulmonary artery diastolic pressure, PADP, and wedge pressure, PCWP, as surrogates for left atrial filling pressure.
Gives more data.
Yes. You can also estimate cardiac output and sample mixed venous blood to calculate oxygen delivery and consumption.
Sounds very useful. But you mentioned earlier questions about survival benefit.
That's the surprising part. Despite all that data, large studies haven't shown routine PA catheter use in critically ill patients improves survival. Meta-analyses support this.
So, not routinely used in vascular surgery.
Current guidelines advise against routine use. The evidence just isn't there for most patients. Maybe a potential benefit in very select high-risk subsets, but not for everyone. It seems we haven't consistently translated the data into life-saving interventions.
Interesting. Are there less invasive ways to get similar info?
Yes, minimally invasive hemodynamic monitoring techniques aim to estimate cardiac output without a PA cath. Things like transpulmonary thermodilution, measuring temperature changes after injecting cold saline, systems like PCHOE or EV1000 use this,
Okay.
or lithium dilution, using lithium chloride injection systems like lidcopolis. Though lithium dilution has contraindications, like patients on lithium treatment or certain muscle relaxants.
Then transesophageal echo TE, that gives a direct look at the heart rate.
Absolutely. T is a mainstay, especially in cardiac and thoracic aortic surgery. The probe in the esophagus gives clear, real-time images of ventricular function.
Seems incredibly helpful. Has it improved outcomes?
That's the million-dollar question. While it provides amazing information, we lack robust evidence showing routine T improves overall outcomes in most non-cardiac surgery, including vascular.
Why might that be?
Well, the correlation between T findings suggesting ischemia, ECG changes, and actual cardiac outcomes isn't always perfect. However, guidelines do say T is reasonable for investigating sudden, life-threatening hemodynamic problems during surgery.
Got it. Lastly, for advanced monitoring, spinal cord monitoring, when is that needed?
That's specialized for procedures risking spinal cord blood supply, like clamping or grafting the thoracic aorta or placing thoracic stent grafts.
Oh,
It helps detect spinal cord ischemia early so surgeons can react.
all this tech is amazing.
Okay,
Switching gears completely. Infection control. Surgical site infections, big problem, right?
huge problem. SSIs account for a large chunk of hospital-acquired infections. They're linked to higher mortality, longer stays, massive costs. That study by Kirkland really drove it home. Increased death, ICU time, readmissions.
And specific risks in vascular surgery?
Yes, things like operating on the legs, procedures after already being hospitalized, diabetes, and previous bypass surgery all increase the risk.
So prevention is paramount. Let's talk antibiotics around surgery time. What's the core principle?
The absolute key is having an effective antibiotic concentration in the tissue at the time of incision. Timing is everything.
How critical is the timing?
Extremely. Studies like Klassen's showed the lowest infection risk when antibiotics are given within the 2 hours before the incision. Too early, during surgery, after incision, or hours later, all significantly higher risk.
What's the go-to antibiotic?
Generally, cefazolin for most vascular procedures. If there's a beta-lactam allergy, then vancomycin or clindamycin are alternatives.
Other key recommendations.
Give the dose 60 minutes before incision. Adjust dosing for patient weight. Redose during long procedures to maintain levels. And keep the post-op course short, often just a single dose or less than 24 hours.
What about for endovascular procedures, the minimally invasive ones? Antibiotics needed there.
It's less clear-cut. We don't have the same level of trial evidence, but recommendations generally support prophylactic antibiotics for stent graft placement, thoracic abdominal extremity.
But not for simpler things like angiograms.
Generally not recommended for routine angiograms, angioplasty, bare metal stents, venous procedures, thrombolysis, or closure devices. But consider them in specific cases like reintervention soon after, hematoma present, long procedure time, immunosuppressed patients, or if other implants are present.
Okay, and skin preparation. How important is that?
Very important. If hair removal is needed, clipping is better than shaving lower infection rates.
Showering beforehand.
Recommended, yes. Shower with normal soap as close to surgery time as possible. For skin disinfection in the OR, alcohol-based prep seems superior to aqueous ones based on meta-analyses.
But you mentioned fire risk.
Yes, huge caution needed. Alcohol is flammable, extremely dangerous with electrocautery in oxygen-rich environments. Need to let it dry completely. Also, some evidence suggests chlorhexidine might be better than povidone iodine, and chlorhexidine alcohol probably best for decontamination before clean surgery.
Wow, fighter risk. Okay, let's move to maintaining the body's balance homeostasis. Why is this so critical during surgery?
Because the physiological changes from surgery and anesthesia heart rate, BP, vascular tone, temperature, glucose can actually be harmful or maladaptive.
How so?
They can increase myocardial oxygen demand, risk of heart attack, cause coagulopathy, impair wound healing, prolong hospital stay, even increase mortality. We have to actively manage these things.
Let's start with drugs affecting the nervous system, like beta blockers. What's their role?
There's been a lot of focus on whether beta blockers reduce cardiac risk. The theory is they reduce heart workload by controlling heart rate and contractility.
So should patients stay on them?
Current guidelines say yes, continue them if the patient was already taking them and tolerating them well. For intermediate or high-risk vascular patients not already on them, starting beta blockade several days pre-op is often suggested, allowing time for dose adjustment.
Another big one is temperature. You mentioned anesthesia causes heat loss. Why is preventing hypothermia so vital?
It's absolutely critical.
Yeah.
Anesthesia causes vasodilation, shunting blood peripherally, plus heat loss from open wounds. Even mild hypothermia, say 34 or 36 degrees C, is bad.
And the body can't compensate well under anesthesia.
Right. Normal responses like shivering and sympathetic activation are blunted, and the complications of hypothermia are serious.
Yeah.
Wound infection, immune dysfunction, coagulopathy.
Coagulopathy. Problems clotting.
Yes. Increased blood loss, more transfusions needed, major adverse cardiac events, even death. The risk of myocardial ischemia is significantly higher in hypothermic patients with coronary disease. Studies confirm it's an independent predictor of morbid cardiac events, and it's linked to post-op arrhythmias like VTach and AFib.
How exactly does being cold affect clotting?
It significantly impairs it. Coagulation factors are enzymes, many are temperature sensitive and work poorly when cold. Standard lab tests run at 37 degrees C might miss this effect.
So the tests look normal, but bleeding is worse.
Potentially, yes. Schmid estimated even mild hypothermia significantly increases blood loss and transfusion risk. Platelets also don't work well when cold. They marginate, change shape, flow dynamics alter, though the drop in count can reverse with rewarming.
And the link to infection.
Hypothermia is a major SSI risk factor. Partly due to vasoconstriction at the wound impairs antibiotic delivery, causes relative hypoxia, plus a general negative effect on immune function.
So how do you keep patients warm?
Multiple strategies. Reduce radiant heat loss, pre-warm the patient before induction, use passive insulation like blankets and active warming devices.
Right.
Circulating water blankets, forced air warmers blowing warm air, radiant heaters, warming 5E fluids, heating and humidifying inhaled gases, and keeping the OR temperature reasonable, maybe 68, 75 degrees Fahrenheit.
Okay, another homeostasis piece. Glycemic control. Blood sugar. Why the focus here?
There's a very strong link between hyperglycemia, high blood sugar, and SSIs. Both a history of diabetes and high post-op glucose levels, often defined as over 200 milli-GDL, are independent risk factors.
What's the mechanism thought to be?
High sugar seems to impair immune function. It might impair vasodilation in the wound, alter adhesion molecules and cytokines, mess with complement, and depress neutrophil function, those key infection fighters. Ramos showed infection risk climbs significantly with every 40-point glucose increase above normal.
So keep sugar controlled. How tight should that control be?
That's where things get interesting. Early studies like Van den Berge's suggested very tight control, like 80-110 milli-GDL, reduced mortality in ICU patients.
But that's changed.
Yes, more recent larger trials like NICE-SUGAR actually found that super strict control led to more hypoglycemia and higher mortality compared to more conventional control, like keeping glucose under 180 milli-GDL.
So too tight might be harmful?
It seems so. The risk of dangerous lows is significant. The current thinking is leaning away from ultra-tight control, unless you have very robust systems to manage it safely. Maybe aiming for a more moderate reachable target is safer if implementation is tricky.
Are there specific vascular surgery guidelines?
Not really specific performance measures or large RCTs just for vascular surgery glucose control. The current general guideline for peripheral arterial disease patients perioperatively is just to maintain blood glucose below 200 milli-GDL.
A pragmatic approach, then. Okay, shifting to anticoagulation and antiplatelets, obviously huge in vascular surgery.
Absolutely. Most interventions disrupt blood flow and the vessel wall, creating a thrombosis risk. Logically, systemic anticoagulation seems necessary, but its efficacy hasn't been rigorously tested for everything.
So it's not always needed.
Evidence suggests maybe not always for preventing local clots in, say, open AAA repair, though many surgeons use it routinely. The need probably varies. Smaller arteries, slower flow might increase the need.
When it is used, what's the typical drug? Heparin?
Yes, unfractionated heparin is the standard, usually given as a bolus just before arterial clamping, either a fixed dose like 5,000 units or weight-based maybe 7,500 units.
How long does it last?
Its half-life is dose-dependent and variable, maybe 30-90 minutes effectively. So for longer cases, you need repeat doses, maybe 2,500 units or 2,550 units every 45-60 minutes.
Do you monitor its effect?
There's considerable variability in response, so monitoring anticoagulation levels, usually with activated clotting time or ACT, is often supported.
Does the variability matter clinically?
Interestingly, the clinical impact of variations from fixed-dose regimens seems small in some studies, like POI6 in carotid endarterectomy. But for things like coronary interventions, an ACT over 350 seconds might be associated with fewer ischemic events, and similar targets might apply to small artery work or carotid stenting.
Any other benefits besides local clot prevention?
Possibly. Some data suggest intraop heparin might reduce perioperative MI risk after AAA repair.
What about reversing heparin at the end with protamine? Always done.
Controversial. Generally used in shorter cases or after intercavitary ops to speed closure or reduce bleeding risk. But protamine carries a small risk, maybe 1% or less, of anaphylaxis.
Risk factors for that reaction.
Insulin-dependent diabetes, vasectomy history, fish allergy, prior protamine exposure, rapid infusion. Some argue just checking an ACT at the end and reversing only if it's very high, like over 400 seconds, is reasonable.
What if a patient can't get heparin due to HIT or antibodies?
We have alternatives. Direct thrombin inhibitors like Hyperbaricin derivatives, or more commonly argatroban and bivaleritin.
How do they work?
Argatroban is given as a bolus and infusion, adjusted based on ACT. No established reversal agent, though, and dose needs adjustment in liver impairment. Bivaleritin also uses a bolus and infusion, ACT monitoring, additional boluses if needed. It can be reversed with recombinant factor, VIA, and cleared by dialysis.
Are they equally effective?
In HIT, efficacy seems similar, though argatroban might achieve therapeutic levels a bit quicker initially.
And reversing other anticoagulants? Warfarin, the newer DOACs.
For warfarin, prothrombin complex concentrate, PCC, is a nonspecific reversal agent. Activated PCC, APCC, is used more for hemophilia. Importantly, none of these nonspecific agents are FDA approved to reverse the newer target-specific oral anticoagulants, except for Praxbind, hydroxyzumab, which reverses dabigatran specifically.
And dialysis.
Generally only effective for clearing dabigatran, not the factor Z inhibitors like rivaroxaban or apixaban. You can see the details on mechanisms, half-lives, reversal for these newer agents in the provided table, table 35.5.
A rapidly evolving area. Now, antiplatelet therapy. Almost all vascular patients need this, right?
Pretty much. Since most arterial interventions are for atherosclerosis, virtually every patient should be on an antiplatelet agent. Low-dose aspirin is generally recommended.
What about adding clopidogrel?
Limited evidence supports routinely adding it in low-risk, aspirin-tolerant patients, but dual antiplatelet therapy, aspirin plus clopidogrel, is crucial after coronary interventions, especially stents.
How long is dual therapy needed after stents?
Minimum 1 month after bare metal stents and 12 months after drug-eluting stents.
What if someone on dual therapy needs urgent vascular surgery? That creates a bleeding risk.
Huge dilemma. The risk of MI if you stop dual therapy prematurely after a stent is significant. Guidelines suggest delaying elective surgeries with high bleeding risk until the dual therapy course is complete.
And if clopidogrel must be stopped?
Aspirin should generally be continued if possible. It's a tough balance weighing the cardiac risk reduction from the stent against the bleeding risk from mandatory dual antiplatelets if urgent vascular surgery is needed.
What's the bleeding risk with just aspirin?
Measurable, but generally small.
Yeah.
Nilepovid's estimated continued aspirin might even reduce perioperative mortality, despite a small increase in bleeding. ACCP guidelines recommend continuing it in high CV risk patients.
But bleeding can be a problem with both.
Oh yes, periprocedural clopidogrel definitely increases intraoperative bleeding and reoperation risk. Like aspirin, it takes 5-7 days for the effect to wear off completely. Most vascular surgeons stop clopidogrel before major open surgery.
What if they bleed due to platelet issues during surgery?
Platelet transfusion is often given for diffuse platelet-type bleeding, but honestly, there's not much solid clinical data proving it works well in that specific setting.
Okay, one last thing in this section. Intraoperative thrombolysis. Using clotbusters during surgery?
Yes, it's been used as an adjunct to mechanical thrombectomy for acute limb ischemia since the 80s. But surprisingly, we lack systematic data on optimal dosing.
Are there risks?
Definitely. A real risk of potentially fatal intracranial hemorrhage bleeding in the brain. It was around 1–2% in the Style and Topaz trials. That's hard to detect intraoperatively, so extreme caution is warranted.
What's typically used?
Recombinant tissue plasminogen activator, RTPA, is most common. Usually a catheter-directed bolus into the clot, then maybe a continuous infusion if lysis starts, often continued for 12–48 hours until reevaluation.
Powerful tool, needs great care. Okay, let's move towards managing blood loss and transfusion. How does the body initially react to blood loss?
Initially, it compensates. Stroke volume increases partly due to less resistance and more venous return, so cardiac output goes up.
Can people tolerate significant anemia?
Data from hematology studies and patients refusing transfusion suggest healthy folks might survive hemoglobin down to 5 or 6 GDL. But, and this is key for vascular patients, those mechanisms depend on adequate fluid resuscitation, and they increase myocardial work and oxygen demand. That might be poorly tolerated if you have underlying coronary artery disease.
Makes sense. What are the risks of getting someone else's blood allogeneic transfusion?
Numerous risks, both non-infectious and infectious. The non-infectious ones stem from immune reactions to foreign cells, lipids, proteins.
Like what?
Anaphylaxis, transfusion-related acute lung injury, TANI, transfusion-associated circulatory overload, TACO, acute and delayed hemolytic reactions where the body attacks the transfused cells.
Which are most serious?
The leading causes of transfusion-related death are trabelli, fatal hemolytic reactions, and transfusion-associated sepsis from contaminated blood.
Tell us more about Trali and Taco.
TRALI is like ARDS, acute respiratory distress, non-cardiogenic pulmonary edema, low oxygen within 6 hours of transfusion. Highest risk with plasma platelets, but most cases follow RBCs just due to frequency. Treatment is supportive. TACO is also within 6 hours, but it's hydrostatic pulmonary edema fluid overload, often in patients with heart failure. Symptoms include shortness of breath, tachycardia, high BP. Treatment involves diuretics, vasodilators, support.
And the hemolytic reactions.
Fatal ones are usually due to ABO-incompatible blood-preventable human error, sadly. It can be hard to spot intraop suspected with sudden instability or coagulopathy. Managing involves airway support, fluids, pressors.
What about other immune effects?
Things like alloimmunization causing fever reactions, FNHTR, rare graft versus host disease, and transfusion-related immunomodulation, or TRIM.
TRIM?
Yeah, a downregulation of the immune system post-transfusion. Historically linked to better kidney transplant survival, but also implicated in increased cancer recurrence, infections, and mortality.
Can reducing white cells in blood help?
Leukocyte reduction does seem to decrease immunologic complications and CMV transmission. Some countries mandate it. Evidence suggests it might reduce fever, mortality, antibiotic use in some groups, maybe even multiple organ failure, and LOS in surgical patients, though impact on SSIs is less clear. It might also lessen the RBC storage lesion.
What's the storage lesion?
Changes red cells undergo during storage, decreased survival, shape changes, fragility, less deformability, oxygen carrying issues. There's controversy over whether this old blood is clinically detrimental. Some small studies suggest higher complication risk with blood stored 17 to 25 days, but large trials are needed.
What about infection risks today?
The biggest risk now is bacterial contamination of platelets, because they're stored at room temp. Much lower risk for RBCs stored cold, though Yersinia enterocolytica is a nasty, albeit rare, contaminant. Donor screening and nucleic acid testing have drastically cut HIV and Hep C transmission to extremely low levels. Hep B is slightly more common, but still rare. Other agents are possible, but exceedingly rare in the U.S. Some viruses like EBV, CMV are transmitted by transfused white cells.
Given all these risks, how do you decide when to transfuse? What's the trigger?
It's complex. The benefit seems intuitive for anemia, but data on morbidity mortality impact in vascular surgery is incomplete. There's no single magic hemoglobin number.
So it varies?
Yes. Data from transfusion refusers suggest tolerance down to HGB 7 to 8 or lower without mortality increase. But other studies, like Carson's, show a link between post-op anemia severity and mortality. So it's a clinical decision based on HGB, overall condition, comorbidities, ongoing bleeding, and symptoms of anemia.
Not just a number then. What strategies are used to avoid transfusion?
Exactly. It's multifactorial.
Yeah.
Proactive strategies focus on limiting blood loss. Careful surgery, meticulous hemostasis, limiting blood draws, keeping the patient warm, managing coagulopathy, careful resuscitation.
What about boosting red cell production?
Preoperative erythropoietin can help in elective ortho, but often impractical for urgent vascular cases.
Can patients use their own blood? Autologous transfusion?
Yes. Preoperative autologous donation, PAD, donating beforehand, its use has declined. Acute normal volemic hemodilution, ANH, removing blood just before surgery, replacing volume, reinfusing later demanding on anesthesia, maybe not great for anemic CAD patients.
What about collecting blood lost during surgery?
That's intraoperative autologous transfusion, IAT, or cell salvage. Devices collect, wash, concentrate, shed red cells. They survive well in vivo. Meta-analyses support IAT reducing allogeneic transfusion in AAA repair. It's common practice for open infrarenal AAA and routine for thoracoabdominal aortic surgery in most places.
Almost there. What about preventing blood clots in the veins VTV prophylaxis?
Surgery itself is a major VTE risk factor, and vascular patients often have other risks. But vascular surgery also often involves things that reduce VTE risk: antiplatelets, intraop heparin, sometimes post-op anticoagulation. Still, VTE prophylaxis is important, part of quality metrics and value-based care.
Okay, just a couple of special techniques to touch on. Laser safety.
Crucial when lasers are used. Needs strict precautions. Warning signs, covered windows, doors, authorized personnel only, and importantly, appropriate laser safety eyewear for everyone, including the patient.
And tourniquets. Not common in vascular, right?
Generally avoided, but can be useful sometimes, like getting a bloodless field for a distal bypass, avoiding clamps on really calcified vessels, maybe speeding up dissection.
Needs careful use.
Absolutely. Proper cuff width, padding, sterile technique if in the field, recommended pressures, prompt inflation, minimizing inflation time, ideally less than 3 hours. And giving heparin before inflation in vascular cases makes sense. Complications like compartment syndrome or PE are rare, but possible.
It's fascinating how even basic tools need special thought here. Well, we've covered a huge amount today, from anesthesia right through to blood management and special tools.
Indeed. Intraoperative management in vascular surgery is incredibly broad and deep, and like we said at the start, it really shapes patient recovery and outcomes.
And it's clear the complexity comes from both the procedures themselves and the patients, who often bring a lot of other health issues to the table.
Absolutely. It truly highlights the delicate balance and the constant vigilance needed from the entire surgical team: surgeons, anesthesiologists, nurses, techs, everyone working together to navigate these challenges.
Constant vigilance seems like the right phrase. Well, there you have it, a deep dive into the critical world of intraoperative management in vascular surgery. We hope this has given you a much clearer picture of all the moving parts during these complex operations.
Hopefully shedding some light on what goes on behind the OR doors.
And if any specific area we touched on sparked your interest, definitely dive deeper. There's so much more to learn. Thanks for joining us on the deep dive.